Today is your 4th day of your internship. It is noon time and you're ready to go grab lunch. However, your senior calls you up and gives you an admission. A 70-year-old male with a past medical history of hypertension, diabetes mellitus, coronary artery disease, status post 2 stents was brought in by EMS after being found by the doctor to have a slurred speech and drooping of his face upon waking up. The patient was last seen to be normal at 9 p.m. the night before. The patient is brought to the ED, stroke code is called, and the patient is being given to you. Current time is 12 p.m. in the afternoon. Alright guys, so based on the case that's presented to you, what do you think is going on with this patient? Patient's got slurred speech as well as a facial droop, and this tells you the patient most likely is having a stroke. Alright, so the diagnosis is pretty straightforward. However, as I said before, what is the most important thing when it comes to stroke? It is time. So now the question is, when was the patient last seen to be normal? This was seen to be normal at 9 p.m. the night before, and right now the time is 12 p.m. in the afternoon. It's almost been about 15 hours since the patient was last seen to be normal. So the real question is this patient a candidate for TPA at this point or not? Clearly you guys have already learned from the previous episode where the patient has to be within 3 hours or 4.5 hours to get any form of TPA. Is the patient a candidate for mechanical thrombectomy? Maybe. Even up to 24 hours you could still do mechanical thrombectomy, but we have to investigate further to see if he's a candidate or not. However, important thing is this patient is not a candidate for TPA. So let's move on into the physical examination. On physical examination, let's look at the patient's vital signs. So vital signs are blood pressure of 200/110, heart rate is 80, respiratory rate is 16, and a temperature of 100 degrees Fahrenheit. On general examination, you see that the patient, when he's talking to you, he's got this slurred speech, alright? And apart from that, you also see that he clearly has a left-sided facial paralysis. Alright, let's move on to the neurologic examination because that is going to be the key component of your physical exam at this point. Alright, on neurologic examination, again, you're seeing a left-sided complete facial nerve paralysis which is affecting above the eyebrows as well as below the eyebrows. And apart from that, you see the patient's also got a right-sided upper limb as well as lower limb loss of muscle power, basically having muscle weakness. However, the patient's got an increased tone and increased reflexes. Now what this really signifies is that the patient is having an upper motor neuron lesion. We'll be going in depth into exactly what this is about in my topic, which is going to be on localizing stroke lesions. For now, let's move on in the clinical aspect of things. So cardiovascular examination is normal, S1, S2 heard, no rubs, gallops or murmurs. Respiratory system normal, vesicular breath sounds are heard. There is no wheezes, crackles or anything else. Lower extremity, there is no swelling, there is no evidence of any form of DVT or pitting pedal edema. Alright guys, so you have completed a very thorough history and a physical examination. Now let's move on to the labs and orders. So this patient is coming with a neurologic deficit. So you clearly know that this patient most likely is having a stroke. So what are the 3 important tests that you must order right now? Alright, so number 1 you guys already know is CT head without contrast and MRI head. Alright, you can do either one of them, whichever one is faster, CT head or a MRI head. The reason we would do a CT head is because you want to rule out the fact that there might be any form of blood in the brain. You know the CAT scan does not pick up an ischemic stroke as early as an MRI, but your goal is not to identify is there a stroke or not. It's rather to rule out the presence of a bleed, because management differs completely. Alright, so fine, you're going to do a CT head and an MRI. Either one of them is fine. Number 2, what you're going to do is finger stick. As I said before, finger stick must be done, POCT glucose, and number 3 is going to be your oxygen saturation in a simple test such as a pulse oximetry. The reason you do these 2 tests with anybody who's coming with a suspected stroke is because hypoglycemia and hypoxia could present like a stroke. So you want to make sure these 2 factors are not present, and that's not the reason that the patient is having these symptoms. Alright, so you're done placing your 3 most important initial orders. So let's move on to the rest of the orders that you must place in this case as an intern. Alright, so your basic labs you're going to order is your CBC. Alright, you're going to order a CMP, complete metabolic metabolic panel. You're also going to get a lipid panel on this patient. You also want to get a PTT, PT, and an INR. And you also want to get an EKG because you want to see if there's any rhythms that's present that's going to predispose this patient to actually having a stroke, such as atrial fibrillation or atrial flutter. So that's important. For that reason, you must get an EKG. Chest X-ray, again, it's not always important, but you're suspecting some form of respiratory pathology, you can always get a chest X-ray as well. Alright, now the other very important test which is very unique to cases of stroke is these tests, which is on your right hand side. So you have to get a CTA head and neck. Now the thing is, it's a CT angiography of your head and neck. Essentially what you're trying to do is you're trying to look at the blood vessels that are supplying your brain. Now remember, when you do a CT angiography, you do give contrast. So when you give contrast, remember there is a chance of contrast induced nephropathy. So if somebody's got a renal dysfunction, this test is not really going to be your ideal choice. So is there an alternative that you could do? Yes, there is. It is going to be MRA. It's a magnetic resonance angiography. The good thing is here you do not use contrast. Alright, but the same test, MRA head and neck. So essentially again trying to see the blood vessels of your head and neck basically supplying your brain. So if you have a patient who has some form of prosthesis or has a pacemaker and therefore cannot get an MRI or MRA head and neck, in this patient what you could do is a CT angio. So the question is really, you have either one of the choice, you have to choose based on your patient. If renal dysfunction, go with your MRA. If the patient has some form of metal in the body and you cannot do an MRA, go for the CT angio. So the choice is really yours. Okay, all right, next you're also going to get an echo with bubble study. Echo with bubble essentially tells you if there is a shunting from your right atrium to the left atrium. Because think about it guys, if you had a DVT on your leg, trace the vasculature, you're going to go eventually into your IVC, which is going to come into what? Into your right atrium. From right atrium, ideally you should go to right ventricle through the pulmonary artery and cause a pulmonary embolism. Never should it cause a stroke. However, if you have a small opening in your septum of the atria between your right and the left atria, now this clot can get shunted into the left atrium and now to the left ventricle, boom, you're going to go and have a stroke. So the presence, when you do an echo with bubble study, essentially tells you if the patient has a patent foramen ovale or an ASD. Alright, so that's the reason you must do an echo with bubble study. Alright, next you're also going to do a carotid duplex. Now the thing is, if you're doing a CT angio of head and neck or an MRA of head and neck, then you do not have to do carotid duplex. Back in the day we used to always do carotid duplex, but now we don't do it much because we do mostly CTA or MRA. Okay, the next test is going to be a 24-hour Holter monitor. Now 24-hour Holter monitor does not have to be done in everybody. If your EKG already shows that the patient has a baseline atrial fibrillation or atrial flutter, then you don't have to do a Holter monitor. But if there is no abnormal rhythm seen on EKG, it'll be a great idea for you to get a Holter monitor because you could still have a paroxysmal atrial fibrillation or atrial flutter. Alright, this completes your orders that you're going to place as an intern. This brings us to our final section, which is going to be on the most important thing, which is assessment and plan. Because assessment and plan tells your senior resident as well as the attendings that you know what you're talking about. So make sure you have a very good assessment and plan. Alright, so based on this patient's history, physical examination, and all the lab tests we've done, and the CAT scan showed yes, the patient does have an ischemic stroke, or the MRI that you did shows that the patient has an ischemic stroke. Fine. Now what are you going to do for treatment of this patient? Question is this, as I always said, what is the number one factor that you must consider in a patient with stroke? It is time. This patient presented after 15 hours. The sad part about this is the patient is clearly outside the therapeutic window for TPA. So this is out. You do not have TPA for this patient. It is out. Alright, now this patient, say you did a CTA or an MRA and you do not find that the patient has any form of large vessel occlusion, and therefore the patient is not a candidate for mechanical thrombectomy either. Alright, now this leaves us to the question, alright, what are you gonna do? So now I'm gonna put this in two scenarios for you. Say for instance this patient was not on any form of home aspirin. In that patient, what you're gonna do is you're gonna start the patient on aspirin right now. Now if I make the scenario a little different, because our patient, remember, he had a stent placement, right? And most people who have a stent placement will be on aspirin indefinitely. So this patient was on aspirin at home. Now what are you going to do? Because he developed a stroke while being on aspirin. So you need to change this. You have two choices. What you could do, if the patient was on aspirin, you can either go and switch this into clopidogrel, all right, or what you could do is you will do aspirin plus dipyridamole. All right, aspirin plus dipyridamole. Dipyridamole is a phosphodiesterase inhibitor and eventually prevents the aggregation of platelets. So you have two options. If a patient was on aspirin at home, you can either switch to clopidogrel or do aspirin plus dipyridamole, and the drug name is known as Agrinox. All right, it's called Agrinox. If you look at this treatment, what you're doing really is you're not treating the acute infarct that the patient developed. Unfortunately, the guy came in late, so that's the problem. However, what you're going to do at this point in time is essentially prevent the next stroke from happening. That's all you can offer. It's sad, but that's all you can offer. All right, guys, so let's move on to the rest of the assessment and plan. All right, so you started the patient on a antiplatelet agent. If the patient was not on aspirin, you're going to start aspirin. If he was already on aspirin, you can either switch to clopidogrel or do aspirin plus dipyridamole. So antiplatelet agent is covered. Number two, what you want to do is you want to start the patient on a high intensity statin. Now recall that the two high intensity statins that's out there is only atorvastatin or rosuvastatin. So again, as I went on with my last video, what you're going to do is you can do 80 milligrams of high intensity statin for 4 days, and after 4 days you can bring it down to 40 milligrams at bedtime. All right, now again, long-term therapy of statin usage is essentially going to be following the ASCVD score, which we will be covering in a different section altogether. However, for acute management, you must remember antiplatelet agent and high intensity statin. All right, so you've done both these parts. Very good. That doesn't solve your issue. There's still a lot of parameters you must remember in any patient with a stroke. So number one, fluids. Alright, so as I said, if this patient is coming with a stroke, he's going to have a chance that he's probably going to have some component of dysphagia. Why do they have dysphagia? Is because of potentially they are going to be having some form of damage to 9th or 10th cranial nerve, or neurologic dysfunction can lead to some component of dysphagia. So if you have a patient who's here with a stroke and you don't want to start him on a feeding, now your senior is going to ask you, okay, what fluid do you want to give this patient? And you're like, alright, the guy is not eating, and the patient's sodium is also about, say, 155. So you're like, you know what, I don't want to give too much sodium in my fluid, let me give some sugar. Maybe I'll do D5 half NS. You think that's a great choice? Absolutely not. You are gonna literally kill this patient if you chose a fluid like this. Now if it was a very minor stroke, it's not gonna impact it so much. However, if it's a large ischemic stroke affecting a very large area, there's a very good chance that the patient can develop cerebral edema. Any form of hypotonic solution you give is going to have a lot of free water. The free water is going to go and swell up your brain. This can cause cerebral edema. What you have to remember is you will use nothing but normal saline. You will only use isotonic solution in a patient with a stroke for the first 24 to 48 hours. That you cannot change with any other fluid. All right, very good. Number two, blood pressure management. Remember what the blood pressure of this patient was? It was 200 over 110. Seems pretty high, doesn't it? What are you gonna do? You're gonna give the patient blood pressure medications? If you guys are saying no, you are absolutely correct. All right, so remember, in a patient who's not received any form of intervention, your target is much higher. If it's severe hypertension, then you can address it. So your target when you're going to start addressing blood pressure is if the blood pressure crosses 220 over 120. Again, drug choices that you have are the ones which you want to use in the form of an IV drip. You have three options. You have a labetalol, all right, or you have nicardipine, and the new one right now we have is clevidipine. So these are your three options, and remember, you don't want to drop the blood pressure immediately to a very low amount. Okay, the maximum you can decrease within the first 24 hours is about 15%. Okay, do not drop the blood pressure more than 15%. This is very, very important. So a person who comes with a stroke who does not get any intervention, your blood pressure threshold is 220/120. If it does not cross it, do not start blood pressure medications, period. When we come to head of bed, there's two schools of thought. One school of thought says if the patient is lying down completely flat, is supine, obviously gravity is going to cause more blood to go to the brain, and this is going to cause increased perfusion of the infarcted area. It makes sense. However, with this supine position, lying down flat, comes the risk that the patient can have a lot of risk of aspiration. So there's some school of thought says, you know what, place the patient in 30 degrees. Head of bed should be elevated at 30-degree angle, and for all practical purpose, honestly speaking, you should go with your 30-degree because this works out to be better. Alright, so head of bed, you're going to maintain the patient at 30-degree angle because why? You want to prevent the patient from having aspiration on top of everything else that's going on. Alright, next is hypo and hyperthermia. As you guys know, fever is bad for the brain. If the patient is having an infarcted area, infarcted brain, fever is not good. So if the patient develops a fever, even though he's coming here with just a stroke, you must do a sepsis workup. You want to make sure the patient is not having some form of infection. You also must take a look at all the medication to see if something is causing, say, neuroleptic malignant syndrome, maybe a serotonin syndrome, maybe malignant hyperthermia. You want to see if you always think broad, and then you can restrict your thought to a narrow thing, but initially always think broad. Either way, my point is hypo and hyperthermia are bad. You want to make sure the patient is normothermic. You could use Tylenol and make sure the patient is normothermic. Alright. Next, number 5, hypoglycemia, hyperglycemia. As you guys already know, the brain and the heart really depend on a lot of nutrition. Alright. So what happens is hypoglycemia is bad, but hyperglycemia is also bad. So you want to make sure the patient's blood sugar lies somewhere between 140 to 180. This is a safe range for all practical purposes. So remember, you want to keep your eye on the sugars as well. Feeding. Are you going to start a patient who came in with stroke and give this guy a nice piece of steak to eat? No, it wouldn't be a good idea. So what you want to do is make sure you want to get an official speech and swallow evaluation to assess the patient's swallowing. If the guy can actually swallow, fine, you can go ahead and start feeding him. If you cannot swallow, then you got to wait. If a guy is not going to eat for 24 hours, it's not like he's going to die. Alright, so make sure you prevent anything that's going to cause some form of aspiration. It's very, very important because it happens very frequently if you do not follow these recommendations. Finally, let's move on to the last component of your assessment and plan, which is in fact going to be your DVT prophylaxis. Unlike a patient who's received TPA or a mechanical thrombectomy, these patients, you should actually start them on chemical DVT prophylaxis at the time of diagnosis of an ischemic event. Alright, so these patients you can actually do Lovenox, or you could do heparin. The dosages is normally going to be Lovenox about 40 milligrams per day is good, or heparin you can do 5,000 either BID or TID. The choice is yours. And along with it, you can also put the patient on sequential compression devices, basically a Venodyne boots. Alright, so DVT prophylaxis becomes a very important subject in a patient with stroke because clearly they are not moving much, and therefore they're going to be at increased risk of developing another pulmonary embolism or maybe another stroke. Alright, because if they develop a DVT. So for that reason, you must put them on DVT prophylaxis. If you recall the previous section when we spoke about a patient who received TPA, you say for the first 24 hours do not use any form of chemical DVT prophylaxis. That doesn't exist here because you did not do any intervention. Therefore, you can clearly start the patient on Lovenox, heparin or sequential compression devices. Alright guys, so this concludes our assessment and plan. However, you have ordered a few tests that you must follow through with. You did an echo with bubble study. When you do an echo with bubble study and say you find out that the patient has a PFO, a small hole between the patient's atrial septum. Now, back in the day, we used to always say you never close a PFO. There's been multiple studies recently which is favoring the closure of a PFO. However, it's a controversial subject. When you put in a device into the atrial septum, it increases the patient at risk for some form of abnormal atrial rhythm, such as atrial fibrillation. So the side effect of putting this device is in fact atrial fibrillation. But for now, I'm not going to go into this subject. You can, depending on which hospital you're working, they could make the decision if they want to close the PFO or not. But the recent studies basically is suggesting closure of PFO, especially if it's a recurrent cryptogenic stroke, which means a younger person who's got zero risk factors but is coming with multiple strokes. For those patients, there is some benefit of closure of PFO, but again, it is not part of guidelines yet. The next test that you ordered was a Holter monitor, a 24-hour Holter monitor. Now, if you follow that and if you see the patient's got paroxysmal atrial fibrillation or atrial flutter, at that point you will follow the CHA2DS score and decide if you're going to give this person anticoagulation or is antiplatelet just fine by itself. So this concludes our section on management of acute ischemic stroke who is outside the therapeutic window. I hope you guys enjoyed this video. Please subscribe and leave any comments below, and I'll see you guys on the next video, which is gonna be on TIA, which is transient ischemic attack. Thank you.